Okay, so I've been very excited today to be joined by Dr. Ben Sessa, who I actually stumbled across on LinkedIn. Ben has quite a complex title and background, so I'm going to hand it over to you, Ben, just to introduce yourself.
Thanks, Angie. Thank you very much for having me here this morning. A great pleasure to join you with this talk. So my name is Dr. Ben Sessa. I'm a consultant psychiatrist, which means I'm a medical doctor specialized in mental health. I actually trained in child and adolescent mental health after that. I'm also a trained and approved psychedelic therapist, trained to work with ketamine, MDMA, and psilocybin. And I'm the co-founder and head of psychedelic medicine at Awakn Life Sciences. And we now have a number of clinics in the UK and Europe delivering psychedelic medicine to patients with mental health problems.
Amazing. I'm glad you took that role rather than me. That was quite a mouthful. So, I mean, and also that also interests, you're based in Bristol too.
Yeah, so I live in Bristol, and our first Awakn clinic was in Bristol. We now have clinics in Bristol, London, and Oslo, with plans to open more. But this one here in Bristol, very proudly, was the first.
Excellent. Love it. So I've got a few questions I've got down here. If you see me looking away from the screen, I'm not being rude. I'm just either writing some notes so I don't want to interrupt you, or I'm checking down on what I'm going to be asking next. So let's just start quite broadly to begin with then. So tell me more about your clinics, what type of things goes on in there, what type of people you're helping, and then I'll probably have some questions off the back of that.
Okay, so the clinics are just a small part of Awakn Life Sciences as a company. It's actually a biotech company which is carrying out research and development and psychedelic therapist training and licensing partnerships with other clinics. But we also have these, so far, 3 physical bricks and mortar clinics. So at the clinics, we are using psychedelic drug-assisted psychotherapy to treat a range of different psychiatric conditions: depression, anxiety disorders of different types, post-traumatic stress disorder, different types of eating disorders, and all different types of addictions. So quite a wide range of psychiatric problems that we cover in the clinics.
Fascinating. And have you found, I'm just curious with the timing of this as well, have you found that there's been an increase of the people that need this type of work since things like COVID, in particular, COVID has come about?
I mean, mental health problems have been endemic in our society for decades and hugely problematic and hugely expensive, a huge strain on social services and health budgets, woefully under-resourced, understaffed, underpaid, and the current treatments, despite best efforts, are poor, with pretty poor outcomes across the board for most chronic psychiatric conditions, even with the very best that modern medicine can throw at them. And so many patients experience what we call treatment resistance. So despite the best efforts of the medical services, they remain lifelong and continuing to struggle with their health problems. And this is certainly worse since COVID. All psychiatric disorders are intimately tied up with psychosocial issues, with where you live, how much money you have, your housing, your education, your support, your parenting, all of these physical health issues, all of these things are tied up with presenting with mental health problems. So when the country's facing a crisis like COVID and the subsequent cost of living crisis, it's quite clear that there will be an increase in mental health problems as a result of that.
Amazing. And I totally support. I mean, I'm not a scientist and I'm medically trained in any way, but my interpretation, particularly the pharmaceutical industry, in the things that you've just mentioned, like anxiety, depression, PTSD, etc., addictions, etc., is also, it's almost like putting a plaster on the wound, and it kind of prolongs it. It takes the pain away in that moment, but it doesn't actually heal it as such. So tell us more a little bit around the difference between what you're doing and how that actually serves to be something that heals it as opposed to something that prolongs it and just takes the pain away.
Okay, so that's a great question, and underpins my lifetime of work in the field of trauma. You are absolutely correct. The psychiatric service and industry has painted itself into a corner over the last 40 or 50 years with this predominantly top-down biological model of using chemicals like antidepressants, etc., to paper over the cracks and treat the symptoms.
Yep.
Most mental health disorders, whether it's depression, anxiety, PTSD, addictions, most of these are underpinned by some kind of trauma, often childhood trauma that's unresolved. And my personal opinion, and those of my colleagues, is very much that the whole diagnostic classification system is not really fit for purpose. It doesn't, if you hurt and abuse and mistreat and maltreat and humiliate a child, they will develop some kind of mental health problem. Now, it might be an eating disorder, it might be a personality disorder, it might be PTSD, it might be an addiction, it might be depression. It doesn't really matter. It's going to happen. And when we have a pharmaceutical-based approach that symptomatically treats the overlying symptoms, we're missing the wood for the trees. So we have these patients in with a history of trauma, and if they're depressed, we give them an antidepressant. If they can't sleep, we give them a hypnotic. If their mood goes up and down, we give them a mood stabilizer. If they're too anxious, we give them a sedative. If they become mildly paranoid and hypervigilant, we'll give them an antipsychotic. 5 different classes of drugs there, none of which are treating the underlying symptom, the cause, but just, like you say, putting a sticking plaster on the overlying presentation and symptom and not curing the patient. And a good analogy I like to use is take something like an infection. Yeah. So an infection is caused by a bug, a microorganism. And one of the symptoms of an infection is a fever, a high temperature. Now, you can take a drug like paracetamol or aspirin, ibuprofen to bring that temperature down, and you feel a bit better. Sure, good, do that. But it's not an antibiotic, paracetamol. It's not going to kill the bug. It's just going to treat that overlying fever. Now, that's kind of what we do when we give patients these daily maintenance drugs. They have to take every single day for weeks, months, years, decades to mask the symptoms of their own underlying problem, which is trauma. Now, what psychedelic-assisted psychotherapy does is it's their first piece of innovative technology that we've had in 50 years in psychiatry to actually have a different approach. It's a paradigm-shifting approach in how we treat mental disorder.
Interesting. And I'm not scientifically based in that way, but I think some pharmaceutical stuff has a place. Like, if you have an infection, antibiotics will help get rid of that infection, whatever. But when it comes to trauma-based things that often sit in your unconscious too, this is where I think what you're doing is so incredibly different. I've never heard of anybody running a type of clinic like you're running. I don't know if there's anybody else. Do you have any competitors? Are you the only one in the world? Where do you sit in terms of other people doing something similar?
We're in a very, very small community. We're certainly the only ones in Europe that are doing this. There's a lot of research going on, and I've been involved in psychedelic research for almost 20 years. We're certainly the first clinic in Europe to do this. There's a few clinics beginning to sprout up around the world that are doing this. And it's all powered by evidence-based research. It's all powered by years and years, decades, in fact, of research that demonstrate that psychedelic-assisted therapies can be superior to the current treatments we're using.
Okay. How do you measure the response that somebody has, or like the impact you're having on people's lives? Obviously, they're going to share things like I feel better or whatever, but how would you measure something being an absolute success?
Well, in the same way we'd measure any other psychiatric treatment. We have a whole host of rating scales and measurements that we do pre and post treatment, so we can demonstrate improvements across whole different domains. So we have rating scales that look at depression, anxiety, sleep, function, life functioning, skills, relationships, openness, empathy, all kinds. I mean, psychologists spend their lives designing these quantitative scales that you can use to measure outcomes. And we use those.
Sure. Amazing. So can you give us a little bit more description on what, like, the science behind it, what actually goes into it, the types of things that you do in your tests and your trials, and just like just more of the behind the scenes work?
Okay. So, I mean, do you want me to talk a little bit about psychedelic drugs and different types and how they work and what they do? I've
got some further questions on that, but yeah, sure. Let's start there.
Yeah. So there's a whole broad range of different drugs that we can call psychedelic. The ones that people most commonly know are things like LSD or psilocybin, magic mushrooms, ayahuasca, which is a compound called DMT, the active component. And then there's drugs like MDMA, which is strictly speaking not a classic psychedelic, but a very, very useful clinical tool. Drugs like ketamine, which is actually a dissociative anesthetic, but is also psychedelic-like, and all sorts of other things like ibogaine. And there's many, many hundreds of different psychedelic compounds within nature and synthetic or semi-synthetic. Now, what they all have in common is this ability to produce an altered state of consciousness. Now, what that means is a state of consciousness in which you are not asleep, you are awake, but your connection with self and the world is altered. Mm-hmm. Now, that might sound weird or even scary or unwanted. But if you think about the concept that, and we touched on this, that underlying most chronic unremitting mental disorders is this sense of stuckness. It's this sense of rigidity. And this rigidity emerges very early in life. And it emerges as a result of our attachment relationships with others, and particularly the quality of our parenting. And when we have poor attachment relationships, and we develop negative narratives about ourselves and the world. I am useless. I am a failure. I am stupid. I am ugly. I am unloved. I am unlovable. It's my fault. I deserve to be exploited. And then we use this as a blueprint for the whole of our lives. And we find ourselves in maladaptive relationships where we remain exploited, making poor choices, becoming addicted to substances, to blunt the edges. All of this is about this stuckness and rigidity of thinking. So now we have this class of chemicals, the psychedelics, which for a few precious hours unhook this stuckness in a profound way. And as I said, that might sound kind of scary because we like rigidity, we like labels, we like order. But if your labels are really bad, if your labels are negative and self-deprecating and are not serving you a purpose, then those few precious hours in a guided, medically led, safe environment can be really valuable to shift that stuckness. So that really is how the technology is working at a fundamental level. It's a technology that shifts stuckness for people who live their lives in a sense of stuckness due to early childhood trauma.
Mm-hmm. So if you're dealing with any particular client, whatever, how do you then ascertain which psychedelic is going to be most useful for that person? Do you have a particular one that would be most useful for anxiety, another one that would be most useful for depression? How does that work?
Well, that's a really good question, Angie. And there's a bit of a problem at the moment in that whilst there's this whole range of helpful psychedelic compounds that are being researched, there's only one at the moment that's licensed as a medicine for us to use in our clinics. So we are using ketamine-assisted psychedelic therapy because ketamine is a medicine with a capital M. That means it's registered and approved as treatment for patients. Oh. All these other drugs, MDMA, psilocybin, ayahuasca, all really, really useful compounds. And in the future, they will be available in clinics such as ours. But at the moment, they're only what we call research chemicals. They're not medicines with a capital M. So you can only use them if you're carrying out clinical trials and research. And there's not that many of those around. We're certainly doing them here in Awakn. We're doing research with MDMA. I've done research with MDMA and psilocybin and DMT and ketamine and LSD in the past. But at the moment, the only licensed medicine to use for treatments is ketamine. So we're using ketamine-assisted psychedelic psychotherapy out of our clinics at Awakn Life Sciences. But we are not just a ketamine clinic, we are a psychedelic medical clinic. And as soon as those other ones become licensed and approved in the next few years, we'll start using them as well.
Mm-hmm. So one of the reasons that caught my eye when I came across your profile on LinkedIn is because I'm a strong believer in this psychedelic stuff and the healing properties that it has and the power that it has. Not going to give a big ramble about myself here, but I spent a lot of time on and off. I'm quite open about my story as well, but on and off in therapy for like 12 years. Then I got into coaching and that was really powerful for me as well, really flipped my life around. But then I got got introduced to ayahuasca, and certainly the concept of ayahuasca. And since then, I've done 4 retreats. I've drunk the tea twice each retreat, so 8 different journeys, 4 retreats, and I'll go as far as saying it's been absolutely life-changing. So that was why I was like, oh my God, you've got therapy, which psychology is my background. Now you're talking about psychedelics as well, which I know has been life-changing for me. Tell me a little bit more about you. Like, what got you into psychedelics? Do you have any personal experiences? Is this something you dabbled with as a teen and just enjoyed it? Or is it something much more profound for you?
I came across psychedelics as a teenager. I was at medical school in London during the 90s, and I was also a DJ and came across the rave scene. And I was knowledgeable about different psychedelics and their healing properties. I was also really interested in the history of psychedelics and the work that was done in the 50s and the 60s before they were all banned, and the great promise they held for biological psychiatry back then. You know, this is all before the 60s drug revolution. These were not banned substances. LSD was going to be the next big thing in psychiatry. It wasn't stigmatized. It was a really, really promising new biological tool. And then, of course, the 60s happened and drugs became demonized, and we've been on this senseless war on drugs for the last 50 years, which, let me say, is the greatest socio-political folly of the 20th century, and continuing into the 21st. And so I knew about all this history. And then as I went through medical school and then qualified as a doctor and was doing medicine and surgery, and then went into psychiatry, I would always ask my tutors, you know, what do you know about this psychedelic work done in the 50s? And they were all like, what are you talking about? That's crazy. That never happened. And I was, well, it did. So I started writing editorials on this and published the first editorial in the British medical press on psychedelics since the 60s when I was a trainee, then got involved in research teams around the world. And at that time, this is 15 years ago, it was very small. There was no one else in the UK interested in it, just a few people around the world. And met David Nutt, Professor David Nutt, who is a pretty well-known pharmacologist in the UK, started working on studies. I partook in the UK's first human psychedelic trial since the 60s, when I was injected with intravenous psilocybin by David Nutt here in Bristol at the PRI, and then working with David's colleague Robin Carhart Harris, involved in studies with LSD, psilocybin, DMT, and then ketamine, and then MDMA. So this was all happening through an academic interest in the subject and a desire to address the balance of this medical education around psychedelics. But at the same time, I was working as a doctor and working in traditional psychiatric clinics. And it just increasingly became clear to me that our treatments are predominantly substandard. And just seeing the distress of my patients who were not getting better and continuing to see this conveyor belt of maintenance therapy treatments, the drugs not working, people being unable to access psychotherapy because they hit this brick wall where they can't get past those traumas because, as I said, this rigidity and stuckness that's been there since childhood. So putting all those things together, they led me to the door of psychedelics, which really are incredibly impressive as potential tools for the future of psychiatry.
And when people have these awarenesses of, like you talk about it getting stuck, for example, when somebody has this awareness, and I can only share my own personal experience from doing ayahuasca, and I did a mushroom retreat as well, but when somebody has that unstuckness, can you describe in your words what you think that is? I know you mentioned before where they have an insight where previously they weren't able to see it. But do you think that therefore it's an immediate shift, or does it still take work afterwards in terms of what they do there onwards?
Yeah, so there's 2 parts to this. It's certainly not just the drugs. It's about combining the drugs with psychotherapy. Just taking a psychedelic drug may or may not be useful or fun or exciting or even enlightening, but it's the combination with psychotherapy that makes it work. All of the psychedelic protocols, whether it's LSD, psilocybin, DMT, ketamine, MDMA, they all involve both non-drug and drug sessions. And it's essential that in a course of the psychotherapy, you have non-drug preparation sessions with the therapist, to build up an agenda and talk about what you're going to do. Then you have guided drug sessions. Then crucially, you have non-drug integration sessions. So it's not just the drug experience. It's very much about using the drug-assisted sessions as a tool, and then using the non-drug sessions to explore the material that came out. But going back to the second part of your question about what does the stuckness feel like? You really have to understand this concept of early attachment relationships and how these early relationships with the primary caregiver become this blueprint for life. Mm-hmm. You know, sometimes I just want to shake my patients and say, for God's sake, you are not a useless, worthless, terrible person. You're a strong, clever, erudite, attractive, intelligent person. But they're not going to believe me. Why would they? Because this imprinting that goes with this early attachment really does stick. So I've had a great attachment, and I think I'm a smart, funny, clever, lovely, generous, kind guy. And if someone came and said to me, actually, you're not actually, Ben, you're a horrible, mean old person. Nobody likes you. You think you've got friends, but they're all lying to you, and you can't trust anyone, and the world's a terrible place. Now, if someone told me that, I just wouldn't believe them. So why should my patients believe me when I tell them that? So you can't just tell them that. You can't even do it in effective psychotherapy often, because they just hit this brick wall where the strength of that blueprint is too great for the work they're doing. They just are convinced they are awful bad people, no matter how much work you do. And this is where the technology of psychedelics come in. It's like a stick of dynamite, and you describe your own ayahuasca experiences. It's like nothing else you've ever experienced. It profoundly makes you look again at your values. And in a way, and this sounds like a bold claim, it's the only tool that we've ever had that can actually tackle that almost irreversible imprinting that's come from trauma. But it needs to be done with great care and skill and guidance and support and integration. But it really is the best way to shift that stuckness that these people present with.
Amazing. And I guess everybody goes there with different degrees of trauma that they've experienced as well, based on what type of treatment they then require. I mean, like I've mentioned a couple of times, I don't claim to be an expert in this at all, but even with my own experiences of ayahuasca, the awakening moment of seeing something so quite profound, I can remember it as clearly as if it was yesterday, and it was as clear as you and I just talking right now. It never really felt like just a hallucination or something. It felt as if it was there happening to me in that very moment.
Yeah, you don't have to keep repeating it. You don't have to stay high forever. You can do the work in the drug-assisted sessions and have realizations and make enlightening realizations about yourself that then can radically shift you going forward.
Mm-hmm. And I think that's one of the key parts as well, is like not just having an awareness, but then how you lead your life afterwards as well is absolutely key. Otherwise, you're just going to slip back into old patterns, and potentially anyway. That was the way I saw it with mine. I had this awareness. I had to change things moving forward as well.
Absolutely. And this is true for any kind of mental health treatment. Mental health is not an on-off switch. We don't either have mental health or not have mental health. Mm-hmm. It's a lifelong process, and it's multifactorial. No amount of Prozac or CBT or even psychedelics is going to cure you and give you lifelong mental health if you have a lousy relationship and a lousy job and an unhappy home and a poverty and racism and exclusion and poor education. This is why, as I said, mental health is intimately tied up with psychosocial issues. We could close half of the prisons and mental health hospitals tomorrow by having better care for single parents with children under 5. Yeah, it's that profound. If we get that early relationship in childhood right, we provide a tremendous resilience that allows you to buffer stress for the rest of your life. The link between early childhood maltreatment and later mental health disorders is the strongest effect size in all of psychiatry. So it is multifactorial. And like you said, you can have these profound experiences, but you then have to do something with it. You have to make meaningful lifestyle choices and moves forward. If you just go back to the same old thing, you just have to keep repeating it. And then we're stuck in that cycle of maintenance therapy again. So we use the psychedelics as a springboard or a platform or a tool with which to have these realizations about ourselves, work with psychotherapy and make changes functionally in our lifestyle going forward. And that often means profound changes, like changes in relationships or career changes or moves, or people go back to college, or they repair relationships, or they move on from relationships. But in a way, the outcome is less important. The important part is how they came to that decision. And they did so in a meaningful and mindful way, using the medicine as a tool. And then they are being themselves. All we're trying to achieve is to help our patients to be the best version of themselves they can be, and to make decisions about their lifestyle with integrity, knowing that it's the true version of them that they wish to be. And this is what these psychedelic tools teach us so well.
Because I know that you're at work at the moment. We had a very brief chat before we hit record today.
Yeah,
So
I
I'm
am.
quite conscious not to mention that there's a bed in the background. So I'll let you talk about that just briefly, Ben.
Yes, this is not my bed. This is one of our therapy rooms. You can see the headphones on the side of the bed there. I'm not carrying out any drug sessions today. I did 2 yesterday. But I'm in our clinic in Bristol where we do this work. Okay,
cool. And how, I'm just curious, do you get a lot of let me start this question again. Do you get most of your referrals through the NHS or anything like that? Or are they all private people? Are you inundated with, because as far as I'm aware, like this is just rife in the world, depression, anxiety in particular. I've never known it be such a big thing. So there's obviously a massive market for what you do. Yeah. But is this something you're inundated with, or is it still something that people aren't fully aware of yet?
Okay, so there's a number of issues here. The bottom line is, no, this is not on the NHS. It's not what we call a NICE approved treatment, which means it's not something which the NHS or insurance companies are currently funding, which means all of our patients are privately funded. And this frustrates us a great deal. And often, say at conferences, people will stand up and be critical and say, the all treatment is just for people who can afford it. It should be on the NHS. And my answer is, I absolutely agree. There is nothing I want more than this treatment to be on the NHS. It absolutely should be it should be funded by public healthcare on the NHS. It works. It's also a fraction of the price of current treatments. If you think about it, I often say this, there is nothing more expensive than an untreated psychiatric patient. They cost millions over the lifetime. Yeah. They don't work. They're on disability benefits. Social services and the family courts come in and take away their children. They offend. They go to prison. They need new livers. They need new legs. They need hospital admissions. They cost millions. So our treatment does appear expensive. It does appear to be a significant spend. But the point is, it works. And throwing good money at bad with poor substandard treatments is costing the NHS millions. So I'm absolutely confident that one day, not far in the future, this will be funded on the NHS, partly because it's the right moral, ethical, and clinical thing to do, but also because it's very, very cost efficient. Because this, as I said, it's the most fundamental and innovative technology that we've had for 50 years to actually shift the pattern. So it works, and therefore it's cheap compared to untreated mental disorder. But absolutely, at the moment, unfortunately, it is self-funded.
Yeah, sure. What would you say, excuse me, your main motivations are? I'm not obviously behind, it goes without saying, you get something out of helping people, healing people. But where would you say your main motivations lie? Is there a particular area of help that people need that you're most passionate about? What would be your answer to that?
I really want to see psychedelic medicine accepted and embraced into mainstream medicine, because I believe it works. Well, it's not just I believe it works. I believe the science that shows it works. We're not driven by some messianic personal quest. We're driven by data. We're driven by research trials. We're driven by the science, what we understand of the neurobiology of psychedelics, and how in combination with psychotherapy, how that works to shift these problems. And my own work, working with abused children for so many years as a child psychiatrist, and then working in addictions, and just seeing this desperately sad, frustrating lack of improvement, It's really frustrating. You know, sometimes I want to be like an orthopedic surgeon. I want to get the person in, mend that broken bone, kick them out of my clinic and never see them again. But so many patients in psychiatry become lifelong chronic service users because we don't treat them properly. And the sad thing is, if you're approaching your psychiatrist in your early 20s with PTSD or severe depression or anxiety disorders or an addiction as a result of childhood abuse, there's a pretty good chance you're going to be going back to that psychiatrist in your 60s or 70s. That is not good enough after 100 years of modern psychiatry. We should be doing better. There are no other branches of medicine that would accept those kind of outcomes. Alcoholism, 90% relapse at 12 months. That's appalling. This is not a rare disease. This is a huge public health problem. We were better at treating alcoholism in the Victorian times than we are today. 90% people are back to where they started pre-detox after the very best treatments that modern medicine can give them. We did a recent small pilot study with MDMA-assisted psychotherapy for treating alcoholism, and we had 21% relapse. Now, that's a huge, huge positive result. And we need to do more research and a randomized controlled trial to explore that further. The ketamine treatments we're using for treatment of alcoholism in Awakn clinics, 86% full recovery after the treatment. You know, this is blowing out of the water the current best treatments in psychiatry. And we're seeing this across the board for all of the research, whether it's depression, use of MDMA for PTSD, psilocybin for anxiety disorders, eating disorders, addictions. All of these trials of the last 15 years have been not just okay, but stupendously strong in terms of their effect sizes. This could be transformative for the way we do psychiatry, and that's what drives me.
Amazing. The stats you just shared there, I mean, what you just compared was a 90% failure rate versus an 80% success rate, basically.
Yeah.
Wow. That's almost flipped it upside down completely.
Yeah, and these are not rare disorders. These are, you know, we should be targeting big common health problems, public health problems. And that's why we're really keen on addictions here in Awakn with our research and development. But in the clinics, we're predominantly treating depression, anxiety, and PTSD. And, you know, as I said, I'm not someone who's particularly wedded to these categorical diagnoses. I think they're all a bit of a red herring. It's all about trauma in almost all cases. And you touched earlier on different sorts of trauma. You know, often when people think about child abuse, they think of what we might call big T trauma, physical abuse, sexual abuse, the sort of thing that hits the social services radar. But I always say, don't take your eye off the ball when it comes to what we call small T trauma, emotional abuse, neglect. I don't love you. Your dad doesn't love you. We didn't want a boy, we wanted a girl. That picture you just painted, that's rubbish. Anyone could have done that. You're fat. You're stupid. You know, no one's being physically abused here. No one's being sexually abused. But that drip, drip, drip emotional abuse all the way through your childhood has a profound effect on the development of personality and a profound effect on self-esteem going forward and a profound effect on the likelihood of developing a serious mental health problem. So there's all sorts of different types of child maltreatment that underpin trauma. And it's not just the big ones.
Yeah, and inconsistency is a huge one as well. So that not really knowing where you stand, if it goes from very volatile to very kind to very loving to very volatile, like Jekyll and Hyde kind of environment, it's very, very unsafe for the children to grow up in that as well, because they have no idea what's going to be around the corner. So they're living in fear and trauma in a way. So
what you do is you develop this exaggerated fear response that makes you fearful and on guard. And then years later, when you're no longer in that noxious environment, you then have this fear response triggered by benign things, like a queue at the post office. Your brain thinks you're still in that abusive childhood relationship, and you have a panic attack and you develop anxiety disorder. And it's all this hangover from early trauma.
And again, like we said at the very beginning, the pharmaceutical industry fixes the symptoms, just get rid of the symptoms. I often refer to it as like a dashboard. And when we're driving a car, if something comes on as a light, it's saying you need to fix that. You don't just take the light out so the light goes out, which is kind of the same thing, isn't it? It's telling you that you need to fix your engine or you need to put diesel in or whatever your case is, as opposed to, oh, that light shouldn't be there. I'll just remove that light so I can't see it anymore. That's almost how
That's a nice analogy. Yeah,
Sorry.
but also I want to make it clear, I'm not an anti-psychiatrist. There is a place for these medicines. You know, some people do respond to the traditional psychiatric medicines like antidepressants. I'm not anti-psychiatry at all. I just want to see it done better. And I want to have a broader repertoire of treatment options. And that includes psychedelic assisted psychotherapies alongside what we're already doing.
Yeah, I think it's a brilliant way you've just put it there, because I support that. I'm not anti-pharmaceutical, but on some of these things, it feels like there could be an alternative method.
I think the biggest barrier to all this is this absurd war on drugs and the stigma that surrounds psychedelics as being banned, illegal substances. The Misuse of Drugs Act and successive Home Secretaries in this country have failed and killed people. Drugs don't kill people, prohibition does. Every single drug death, which is an awful lot that I've worked with, every single one has been due to the prohibition of that drug. Most drugs are taken most of the time by most people safely and benignly. The people who struggle with drug misuse and addictions are people with trauma and early life problems. It's not the drug, it's the psychosocial circumstances in which they're taking them. And this is massively increased by banning drugs. If drugs are dangerous, they need to be regulated, not banned. So driving cars is dangerous, so it's regulated. Riding horses is dangerous. Scuba diving is dangerous. We don't ban these things. We just develop a system in which they can be done in a regulated way. When we ban them, they don't go away. We just hand the franchise to the mafia, and they deal with the production, supply, distribution of drugs, and they have no standards and no customer services and no CEOs and no supervision or scrutiny, and they can do what they want and they make a lot of money. But drugs don't go away. We just criminalize people and reduce their access to services, and we make what could be a dangerous situation a hell of a lot more dangerous. It's absurd. If we and we need a new approach, whether or not you use or like drugs or not. You know, so take, for example, horse riding. Yeah, I have no interest whatsoever in horse riding. Couldn't care a toss about horse riding. But I'd like to know that the regulatory system in place for horse riding is the right one, even though I'm not interested, especially if it's costing me £20 billion a year in taxes, mopping up the problems by the terrible horse riding laws. So that's the situation we're in with drugs. Even if you hate all of these other drugs, and I'm not counting cigarettes and drinking because they're not drugs. This is the prevailing narrative. The other drugs. Even if you hate all the other drugs, the drug laws are wrong for you, the non-drug user. They are damaging you. They are costing you. They are not sorting out the drug problem. So by far the biggest barrier to all of this work that we're doing is the stigma induced by the appalling, unethical, unscientific, unpoliceable, immoral Misuse of Drugs Act. And successive Home Secretaries have blood on their hands for the deaths of young people, for allowing this to continue and not listening to the scientists and reviewing these policies urgently. And interestingly, that we're in, it's the Labour conference today, and I wonder what we're going to hear. But politicians on all sides are just the same. We will not be soft on drugs. You cannot be softer on drugs than banning them. It's the absolute softest way of managing the problem. Be clever, listen to the scientists. We can change that 20 billion into taxable income with a stroke of the pen from the Home Secretary. But we persist in apathy with these dangerous policies, and it reduces patients' access to clinics, and it will change, and it is shifting. And we're seeing these shifts all over the world. We're just embarrassingly slow in this country.
I can see you're very passionate about it. Why do you think it has been so misunderstood? I know you said that some people just say no, and it's a poor way to do it. It's just like to blanket everything. But why has it been so misunderstood? Do you know the history behind that?
Well, I think in terms of, the Misuse of Drugs Act and the war on drugs, it's just a long history of many hundreds of years. It's based in some very sinister historical roots of racism and exclusion of certain social groups. And it's just apathy. And it's just culturally, we've just got used to, well, we've got cigarettes and we've got alcohol. and they're enough problem, so having more would be more of a problem. So, okay, if that's a claim, let's look at the data on that. The data suggests otherwise. The data suggests having a less prohibitive stance reduces the harms, the dangers, the deaths, and bizarrely, even the usage of these other drugs. Take Amsterdam and Holland, where they have access to cannabis, they have far fewer users per capita than we do, you know? Portugal, where they've decriminalized all drugs since 2001, they've reduced by 2/3 rates of injecting HIV and hepatitis C. So I think that both politicians and the general public who are being fed these lies about the value of the Misuse of Drugs Act are just not looking at the data, because the data suggests otherwise. Regulated drugs markets to allow people to not be harmed by drugs, and you just pull the rug out from under the mafia in one swift move. Suddenly there's, you know, Keir Starmer said the other day, drugs are bad because they're associated with crime. It's like, what? Well, that's because they're illegal. So if that's the only thing about them that's bad, they're associated with crime, that's absurd. So drugs, you know, it's just topsy-turvy. And we're creating a rod for our back, and it's costing lives and an awful lot of money. And it can be so simply reversed. And it is in other places. And in the meantime, I mean, the whole recreational use is another issue. In the meantime, these are really, really useful medicines that can be used very, very safely and very effectively in psychiatry.
I know that your background is with working with children as well, and like child psychology. Do you work with minors now, or are you strictly with adults?
Very little these days. I'll see occasional teenagers. Haven't worked with little ones for a long time, but I specialized in child and adolescent psychiatry and was working as a consultant with young children and teenagers for 10 years or so before I went into adult addictions. And it was a tremendous education. You know, I think all adult psychiatrists should do a good significant 5 or more years working with children and adolescents, because as I've said, you know, it for me hugely informs this developmental approach, in that early childhood experiences become the blueprint for adult mental health. And that part of my work and the interest in trauma and adults with mental health problems is hugely informed by the very, very close working with abused children for all those years. So it's a really important part of my education. Yeah.
Amazing. So in terms of wrapping up, where can people find you? How can people contact you? If anybody's watching this that feels that they want to reach out, what's the best way for them to do that?
Awakn, spelled Awakn without an E, which is kind of a thing these days, I think. Awakn Life Sciences. We have 2 websites, one that's a kind of corporate website that explains all of our research and development and wider plans, and then Awakn Clinics, which describes our clinics in Bristol, London, and Oslo, and our plans for expansion. We're aiming to have 15 to 20 clinics in the next 5 years or so. Wow. So go to our websites. As a patient, you don't need a medical referral. You can just apply online, and then we'll get right back in touch with you and meet and invite you to come and meet us at the clinic and explain the treatments. On the websites, it's all very clearly laid out in terms of how we use the medicine, how many sessions, how much it costs, what kind of support and that kind of thing. So it's all at the awakenlifesciences.com or awakenclinics.com, all the information, or pop in to our lovely building here in Bristol. It's sick.
I'm going to hold you to that one. You've given me the offer. I'm going to definitely get myself there.
Bristol, are you, Angie?
Say again, sorry?
Are you in Bristol?
Yes, I am, yeah.
Right. So yeah, drop in. It's really nice. It actually used to be a Tali restaurant here in Clifton, and it's now Scandi chic. And we got a lovely space. We have just 3 consulting rooms here for our treatments. In London, we have a larger unit, 8 beds, and we have more opening on the way. Manchester, Dublin, Edinburgh coming up soon. So drop in, say hello, go to the website to get more information about how to apply.
Yeah, amazing. Any final thoughts before we say goodbye? Anything you'd really like to add?
You know, like I said, stigma is the biggest barrier. And we have decades and decades of negative stigma around these and other substances to undo. So thank you, Angie, for your work in exposing this and demonstrating this. I mean, as you can see, I'm not some crazy bearded guy in a kaftan with sitar music playing. I am a boring, conservative, evidence-based scientific doctor. And I'm driven by the science and the evidence on this. And I'm driven passionately by my empathic regard for my wonderful patients and my desire to see them get better. And, you know, psychedelics is not some messianic purpose for me. It's the right thing for medicine and science and patients. And I really, really hope that we continue to see that grow and become mainstream in medicine.
Yeah, as I do too. I think what you're doing is brilliant. So I want to say a massive thank you to you, Ben. It's been an honor speaking to you. Appreciate you giving up your precious time. So I'm sure, excuse me, I'm sure you've got a lot on in your diary each day. So thank you very much for being here.
Thank you, and good luck.
You too.